Good afternoon, everyone. My name is Jenny Rank. It's my pleasure to serve as the host today for our final CGNE seminar of our spring series. On behalf of our team, thank you for joining us today. This program is being provided by the Teresa Neese and Helen Diskovich Center of Geriatric Nursing Excellence at the Penn State Ross and Carol Neese College of Nursing, in collaboration with the Office of Outreach and Professional Development, the Center of Nursing Research, and Age-Friendly Care PA. Today's seminar, Implementing Nursing Safety Huddles for a Long-Term Care Facility, a Quality Improvement Initiative, will be presented by Tracy Kephart, DNP graduate student at the Penn State Ross and Carol Neese College of Nursing. Before this informative session begins, we have some disclosures and announcements. Penn State Ross and Carol Neese College of Nursing is approved with distinction as a provider of nursing continuing professional development by Pennsylvania State Nurses Association, an accredited approver by the American Nursing Credentialing Center Commission and Accreditation. Participants with a valid RN license who attend the entire Nursing Continuing Professional Development program can earn 1 contact hour. Partial contact hours are not awarded. The topic of this education is non-clinical, and therefore we did not identify, mitigate, or disclose any relevant financial relationships. As a reminder, the seminar is being recorded, and once Tracy is done presenting, you can put your questions either into the chat feature or use the raise hand feature, and we will unmute you, and we'll have the Q&A portion after her presentation. The post-event survey link will show up in your browser at the conclusion of the webinar, and it will also be emailed to you within 24 hours. While it's required for RN seeking contact hours, we do ask everybody to complete the evaluation to assist with data collection. And to earn contact hours, Zoom in and out times will be recorded, and the post-event evaluation must be completed within a week of the seminar. The Nursing Continuing Professional Development certificates will be emailed to all participants meeting requirements within 1 month. And if you have any questions, please feel free to email us at cgne@psu.edu. Next, I would like to introduce Yogen Kazmer-Lau, who is a CGNE graduate student affiliate. She's been very engaged with our center in a multitude of ways, and most recently has helped to analyze our 2023 seminar data for our spring brunch. And she's pursuing her dissertation in pain assessment and management in people living with dementia. Thank you, Yogen, for introducing Tracy today.
Thank you, Jenny. Tracy is an accomplished nursing instructor at the Ross and Carol Neese College of Nursing, Altoona campus, bring a wealth of knowledge and expertise. With 20+ years of clinical and administrative experience in acute care, critical care, and long-term care, Tracy provides instructions to both undergraduate and second-degree nursing students. She holds a master's degree in leadership and management from Western Pennsylvania and is pursuing a Doctor of Nursing Practice in leadership from PSU World Campus, which she will complete this May. Tracy is also an esteemed Teresa Neese and Helen Diskovich Center of Geriatric Nursing Excellence affiliate nursing graduate student and work closely with CGNE as a RICE nurse educator, providing invaluable guidance and mentorship to long-term care facilities. Welcome, Tracy.
Thank you, Jolyn, for the introduction, and I am happy and delighted to be with you all today. Give me just a second. As we all said that, when we first practiced this and how things work. Okay. Jenny, are we good to go? We can see everything?
Yep.
Awesome. Good. It worked on my end too, so thank you so much. So yes, I am here to present the Huddle implementation at a long-term care facility, a quality improvement initiative. I want to take a moment to acknowledge my DMP advisor, Dr. Walgas, my committee of Dr. Maynard and Motter, and the facility for supporting me and allowing me to work with them on this project. So a little background on why this quality improvement project started was concerns about patient safety and communication. Promoting patient safety is among the healthcare system's most important goals and challenges worldwide. Communication is not just an issue, but a pivotal one in interprofessional teamwork, as evidenced by extensive research showing the alarming rate at which communication errors are identified as the cause of unwanted incidents in health services. Actual and potential patient safety risks typically result from individual failings, systematic weakness, and environmental factors. The problem and significance of my project were that there needed to be a structured shift change among the nursing staff. The aides reported to each other down the hall, the LPNs are in another area to themselves, while the RN is in a different area receiving report. And this led to poor communication and teamwork within the department. So how can we promote patient safety while communicating with others and healthcare team members? By implementing a huddle. A huddle is a well-known communication tool in the healthcare. We can create a purposeful framework to enhance communication and relationship skills in less than 10 minutes. This will empower our frontline staff to address quality of care issues, sustain improvements, and foster an engaging staff. And the potential for improved teamwork and clear communication is significant, leading to a positive patient outcome. Before I discuss the major themes that emerged from the Quality Improvement Project, the available knowledge and strength of evidence briefly found to be very broad, with the majority of the articles from a level 6 of a single descriptive study. So the major themes that emerged from the literature were falls, safety huddles in acute care setting, huddle benefits of safety communication, team members' perspective, and huddle intervention design. Furthermore, I have chosen to implement the highly effective Team Steps 2.0 for long-term care as a well-documented teamwork tool that the Agency of Healthcare Research and Quality has proven to enhance communication and patient safety significantly. There is significant literature on adverse outcomes resulting from safety concerns in long-term care. Every second of every day, an older adult, age 65 or greater, suffers a fall in the United States, making falls the leading cause of injury and deaths in this age group. Of the 1.6 million residents in nursing facilities, approximately half fall annually. Fall-related injuries decrease the residents' quality of life and the ability to function. And fall rates in long-term care settings are about 3 times that of elderly community dwellers, equaling 1.5 falls per bed per year. Approximately 25 to 50% of first-time fallers will experience recurrent falls. While the available knowledge and benefits focused on acute care settings, results revealed that huddle implementation leads to improved efficiency, increased accountability, empowerment, and a sense of community. Results revealed that huddles help expedite the process of reaching treatment goals, reduce clinical mistakes and near misses, reduce patient incidents, and help enhance the teamwork. Implementing team huddles improve the accountability of identified issues, problem solving, and teamwork enhancement. So the National Academy of Medicine stated that collaborative interprofessional teams are best positioned to meet the challenges of the evolving health system. When providers work effectively in a team, patients receive a safer, higher quality of care. And literature suggests that huddle implementation improves efficiency, staff accountability, and empowerment, and significantly enhance patient safety, thereby reducing patient harm. Studies also shown improvement in open team communication using those huddles. While significant research focused on implementing huddles, the healthcare team members' perspective must be considered. Coming together daily increased that organized and systematic communication and that overall awareness. And staff perceive huddles to be a safe space that supported communication, collaboration, and teamwork, and played a key role in strengthening a culture of safety within the healthcare setting. The literature highlights various huddle intervention designs, specifically focusing on communication tools, such as the team steps, the SAFE, which stands for Situation Awareness for Everyone, the RE-AIM, the HO2 or the Huddle Observation Tool, and the PDSA. The practical implementation of initiative as a huddle must have a definitive structure for supporting sustainability, and delivery and education methods did vary among these huddle interventions. So to illustrate the design and implementation of my project, I chose to use Lewin's changed model. Lewin's three-step model of unfreeze, moving, and making the changes and refreezing is the most widely used change management model and has become a foundation for developing other models. In addition to Lewin's change model, Team Steps 2.0 for long-term care was applied to assist in identifying the needed changes and focus on the evaluation and design. This slide described the problems and the steps to reach the project's desired outcome that I will discuss further in the phases. So a little further about Team Steps. Team Steps 2.0 is based on a framework of 4 teachable, learnable core teamwork skills of communication, leadership, situation monitoring, and mutual support. Team Steps 2.0's 3 phases are based on phase 1 of assessment, planning, and training, phase 2 of implementation, and phase 3 of sustainment. Team Steps 2.0 is a versatile and effective tool successfully applied in various areas, including program development, project implementation, and evaluation. So the framework and competencies seen here were adapted to fit the quality improvement project. The team structure capability identified the components of a multi-team system that must work together effectively to ensure patient safety is addressed to all healthcare team members and leaders. Structured communication is a cornerstone of our operations, ensuring that information is clearly and accurately exchanged among the healthcare team members. And this approach, championed by our leadership, maximize the activities of the healthcare team members, underlining the importance of each individual's role, ensuring that team actions are understood, information changes are shared, and team members have that necessary training resource. The situation monitoring process involves scanning and assessing situational elements that provided information for understanding or maintaining awareness to support the team's functioning. And finally, mutual support as an essential aspect of teamwork is the ability to anticipate and support team members' needs through accurate knowledge about their responsibilities and workload. So within Team Steps, Module 1 provided communication concepts and tools, and examples of the communication tools used for training the team were the SBAR. Using SBAR concept of a structured communication framework can help teams share information about patients' condition, and also closed-loop communication is a powerful tool that used verbal feedback to confirm that messages are correctly understood, and it employs methods such as callouts, checkbacks, and teachbacks to ensure effective communication within the healthcare team. Team Steps does provide a video example of SBAR and closed-loop communication to view. And then callouts is a vital tool in healthcare communication. It relays critical information, especially in situations that demand immediate attention. By calling out such information, the team can anticipate and prepare for next steps in a patient care. Directing this information to a specific individual by name is crucial for effective communication. And then while call-outs are most common in hospital settings, they also are appropriate during medical emergencies and can be used in the long-term care settings. And it is essential to call outs critical information so that other team members are aware. Additional tools that can be used were Anticipate, which stands for Administrative Data, New Clinical Information, Tasks to be Performed, Illness Severity, Contingency Plan for Change, and then also the SHARQ, which is Situation History Assessment, Recommendation, Results, and Questions. So Module 2 provides information for leaders to take part in the training on concepts of Teen Steps tools and the steps for sharing and planning of the huddles and debriefing. So of course, there's always news and updates. So in May of 2023, about halfway through my project, the Agency for Healthcare Research and Quality updated Teen Steps to address healthcare delivery and learning methods changes and emphasize patient engagement at the center of care. The 3.0 was developed with teamwork and team training experts, including patients and family caregivers. And the update curriculum consolidated content into one integrated resource, offering a comprehensive and flexible approach for your training needs. With its active learning strategies and module courses and design, the update training empowered you to adapt the learning process to your unique circumstances, giving you control over the professional development. And of the 5 emphases, patient-focused teaching involved family caregivers, provided teaching approaches, communication, and patient engagement methods. And they integrated the Team Steps platform as a single resource platform with prior versions in separate care settings. Module course designs can be taught in sessions of varying lengths and is recommended for short training sessions. And active learning strategies provided various options for helping people learn to teach and using discussion exercises and video-based simulations. And then finally, emerging team challenges and opportunities are about maximizing patient safety and connecting effective teamwork with frontline care providers, well-being, job satisfaction, and reducing burnout. So to get back to my quality improvement project, the specific aims of this project did include the following: of developing a daily safety huddle protocol for a local rehabilitation to implement effective communication and teamwork among healthcare team members and a short-term rehabilitation department, and measured attitude and perception outcome using the Team Steps evaluation tool for long-term care, and measured the number of huddles completed and attendance during the evaluation period, and reported identified outcome evaluation findings to create sustainment recommendations. So the Safety Huddle Quality Improvement Project was implemented in a 240-bed family-owned long-term care rehabilitation and wellness facility in central Pennsylvania. And the project setting is a 60-bed short-term rehabilitation department within the long-term care facility. Nursing administration identified the on-site lead champions as a registered nurse and 2 licensed practical nurses. And Team Steps 2.0 team training was provided for all staff to promote teamwork and communication skills during project implementation. And implementation occurred over an 8-week time frame, utilizing a descriptive design. So for the phases of starting with the unfreeze, the project involved an RN, LPNs, and nurses aides. The total number of staff expected to participate was 15, and I provided Team Steps 2.0 education to all staff members using the following process, with a planned education session for each staff member based on shift times, a scheduled Team Steps training for improving communication and teamwork skills with the staff in 30-minute increments in person, and I made copies of Team Steps material for staff distribution posted copies on the bulletin boards and break rooms for that reinforcement and training reminders. And it provided the project champion with 5 evidence-based articles on huddles and communication. And these articles described teamwork and communication tools and provided evidence to support the use of huddles in practice. I also provided signs throughout the department for team steps, team huddles, communication, and safety reminders for them. And I scheduled practice runs using the Huddle agenda sheet and attendance logs sheet 4 times, including weekends with the project leader, the RN, and the staff. And this occurred at the nurses station at the beginning of change of shift by gathering all the staff members, including the night shift and the oncoming daylight staff. And this was led by the RN unit manager for practice only, and included but was not limited to safety concerns, isolations, admission and discharges, and appointments and updates regarding the residents' matters, and any reminders to staff. And if there was additional concerns or issues lasting more than 1 minute, they were discussed separately after the huddle. And the RN, which is the project champion, went around the group and asked if anyone had any other concerns or comments for the day. And this was an open discussion among all team members and was non-judgmental. And the huddle was short, lasting less than 10 minutes. And then we reviewed feedback immediately after the practice run with the staff for adjustments needed in huddle formation and timing. Oops, I apologize. So this is an example of the safety huddle agenda sheet used as a guide for huddle communication. And this could be modified to fit the needs of the facility or the department with the staff's input. So phase 2 was the change, and we started the huddle execution that Monday after the weekend practice huddle. I gave staff the Team Steps 2.0 attitude and perception questionnaire to complete for pre-test implementation. And then a small incentive was given for the completion of the questionnaire. And they began the regular morning safety huddles as practiced during the huddle education phase. And they rotated huddle leaders between the RN and the LPNs for experience. And I was available throughout the project timeframe for additional questions, training, and reinforcement and guidance. And I also collected the weekly huddle agendas and attendance sheets to monitor progress, reinforcement, and address any concerns if needed. I also spoke to multidisciplinary team managers in person before implementing the huddle and encouraged participation in information sharing. During the second week, I followed up with physical, occupational, and speech therapy to attend the huddles. So phase 3 was the refreeze. And at the end of the 8 weeks implementation timeframe, I provided staff with a Team Steps attitude and perception questionnaire to complete for post-test implementation. And then another small incentive was given for completion of the post-questionnaire. And I also encouraged staff to continue safety huddles for sustainability. So a little about the study. The quality improvement project evaluation used Team Steps 2.0 attitude and perception as a measuring tool for increased knowledge of attitude within the department and perceptions related to teamwork with understanding Team Steps concepts for the project. And to assess and review completion, I again collected the daily huddle agenda sheets and attendance logs for data tracking. And at the project's conclusion, pre and post data collection and analysis were conducted to determine whether the program implementation proceeded as planned, and a paired t-test was utilized to assess the impact of the intervention by comparing the Team Steps pre and post mean statistical data on team structure, leadership, situation monitoring, mutual support, and communication. So the Team Steps tool for attitude questionnaire, also known as the TTAQ, is a self-reported tool measuring individual attitude related to the core competency of teamwork captured within the Team Steps and comprised of 30 questions. And the TTAQ comprehensively assessed the 5 core teamwork constructs, team structure, leadership, situation monitoring, mutual support, and communication. And the results measured on a 5-point Likert scale provided a detailed understanding of attitude towards these aspects of teamwork. In addition, the Team Steps 2.0 for long-term care attitude and perception questionnaire was used for project evaluation. The Team Steps Tool Perception Questionnaire, known as the TTPQ, sometimes this could be a mouthful, is a self-reported measuring individual perception of group-level team skills and behavior. This 35 question assesses the 5 core teamwork constructs of team structure, leadership, situation monitoring, mutual support, and communication. And the 5 items were measuring the team structure, leadership, situation monitoring, mutual support, and communication. This was an example of communication section of the questionnaire. This is showing the communication section. So for ethical considerations, this project did not interfere or interact with residents and was with staff only. And there was no identified potential conflicts of interest, and all collected data was kept confidential and only accessed by the project leader. So the budget, the minimal cost were included in this project. The Team Steps training was free and permission was unnecessary. And the minimal cost associated with printing the material and the tools used for team building, communication, and skills training was provided by the facility for less than $50. I did add a small associated cost of $350 with staff completing the questionnaire as an incentive. And the value of this project far outweighed any cost of open communication and teamwork for all healthcare teams. So in the results, the evaluation was conducted using the 5-point Likert scale to include the team structure, leadership, situation monitoring, mutual support, and communication. And the score ranged from the highest of the 4.3 to 5 to the lowest of the 1 to 1.8. And the results of the pre and post implementation assessment survey are displayed. And after 8 weeks of Huddle implementation, participant results from the pre-intervention and post-intervention attitude and perception of staff did remain the same. Compared with the paired t-test, the mean response to the pre and post showed no significant change in attitude or perception. So in summary, implementing the daily safety huddle protocol is a feasible in long-term care facility. Although the key findings related to the specific objects were that the huddles did not significantly change the staff's attitude or perception, they did change the awareness of huddles in general. And focusing on additional teamwork training and reinforcement may be needed to evaluate for future implementation. And this project strength included partnering with the facility administration and education department. And the quality improvement project was a feasible way to strengthen communication and teamwork. And this project was easy to implement, and free access to Team Steps 2.0 for long-term care was a valuable training resource. As a result of my effort, it did not require a large budget or the need to include gift cards given to the participants, and that was an incentive for me. So many lessons were learned regarding falls, safety, communication, and team members' perspective regarding the huddle design. It is essential to carefully integrate healthcare team members' education into a daily safety huddle. Evidence showed that huddles should be utilized in all healthcare settings and sectors for patients' communication and teamwork. And bringing about change in an organization is challenging. And Kurt Lewin's 3-step model for change has become the best known and arguably the most influential approach to organizational change. Additionally, for orientation, newly hired nursing staff are provided with Team Steps, team interaction, and teamwork training as part of their onboarding process. And the Team Steps training program can be customized and implemented across different departments within a healthcare institution to improve teamwork, communication, and patient safety. So this project did have some limitations. It was limited to one department in the facility with a small participant size of full-time employees. And this short duration of 8 weeks of implementation limited the data collection, and extending the data collection could be considered in the future implementation of another department. And one area with great potential for improvement was the RN leadership. And having and providing leadership support for ongoing sustainability is the key to understanding and supporting staff, especially with high turnover rates and inconsistency with regular staff members. Recognizing the potential, we can strengthen the leadership support by enhancing the project's outcome. And I also was on site multiple times at the beginning of the project for guidance and reinforcement, and then with a schedule less frequently towards the end, which could have contributed to leadership needing to be more involved. And it was suggested that ongoing support might help to be consistent with ongoing huddles at the change of shift. And also a potential variable of 2 fewer participants for post-implementation as opposed to pre-implementation, as well as RN participation of only 53% of the time may have influenced the project's outcome. So in conclusion, overall, there was a strong staff support to implement the project during challenging times of staff turnover, shortages, and scheduled vacation and leadership changes. Implementation of the daily safety huddle proceeded as planned, and staff reported that they did appreciate the exchange of resident information as a group for valuable information and discussion. And literature reinforced this coming together at shift change for team members' collaboration in an open communication and teamwork forum, and precisely describing safety huddles as a feasible intervention to improve teamwork and safety culture, especially among those nurses. And this project had established a strong foundation by successfully integrating a change of shift morning huddle and the addition of an afternoon shift change huddle. And a significant develop was the adding of a huddle board, as seen here, now located in a secluded area behind the nurses' station. And this board served as a centralized source of key information for the day's huddle agenda, enhancing communication and ensuring everyone is on the same page. And the nursing administration had expressed its commitment to sustaining this project in the rehabilitation department and has outlined plans to extend it to other departments in the coming months. And while statistically differences were not achieved with attitude and perception within the project timeframe of the safety huddle, the results clearly demonstrated the huddle impact on communication and teamwork within the facility. And the implementation of a change of shift safety huddle had proven to be a significant step toward providing the best care for patient safety. And it is crucial to identify ways of further improving teamwork and communication with staff and leadership, especially in long-term care. And the use of team steps and Lewin's change model has not only provided guidance and training, but also facilitated increased communication and information sharing. And finally, I'd like to express my gratitude to the Tressa Neese and Helen Diskovich Center of Geriatric Nursing Excellence for providing me with a grant to cover the expenses related to the gift cards. These gift cards range from $15 to $25 and were given to staff who completed the questionnaire. And once again, thank you so much for your support. Here are my references, and I thank you for your time, and I'd be happy to answer any of your questions that you may have.
Well, thank you so much, Tracy, for the wonderful presentation, and congratulations on completing this project. I'm very happy that CGNE was able to support you through this project, and thank you just for highlighting the importance of the communication and teamwork and patient safety and long-term care. I think we gained valuable insight on not only the strategies, but also the challenges that we see within long-term care communities. So if you have any questions for Tracy, you can please put them in the chat now. Or if you would like to ask your questions aloud, you can use the raise hand feature, and we will unmute you and you can ask your questions aloud. We'll probably end the session around 12:55 to allow you all time to complete the post-event summary. So we have about 20 minutes for question and answer. We have our first question in the chat is from Khalid, and he asked two questions. First, he said, this is well designed. The first question was, how did you take care of home care residents while staff are in the huddle? And then the second part of the question is, did you gather qualitative data?
So this was right at the change of shift. So where the staff and gathered right as the incoming staff and the outgoing staff, they gathered, and that's why it was less than 10 minutes. So then if they had to individually discuss further like change of shift, so it didn't really interfere with the residents at all. And then, yes, we also included, like I said, the multidisciplinary teams in addition, but the way that they're scheduled time, the housekeeping were not there. And that was something that we discussed with administrative as other additions to our limitations to include other multidisciplinary teams.
I really love that you considered the interdisciplinary approach and kind of all of those who have eyes on the residents throughout the day. I love that.
Thank you. Thank you.
And did you gather qualitative data?
No, we left with the quantitative data, just the way that the project was designed. So, and that would be something maybe for future. As I've went through this, there's a lot of ideas and now feeling more and more comfortable with research that I would like to do something with a qualitative. And I think, again, taking this even further and getting further input would definitely be interesting, especially the staff had so many, they were really valuable and I really appreciated, and I like that. And I think they like that too, that they really felt part of this project.
I love that kind of, making them feel like their input is valued and kind of taking that into consideration. We have Kelly Wolgast, your advisor, has raised her hand. So Kelly, let me unmute you here to ask your question.
I will. Thank you. Tracy, as always, I love to hear you present this. I don't really have a comment because, of course, I've followed you along this journey, but I just wanted to mention that I hope those on the call today have seen the news that just came out this week from CMS about the new nursing staffing rules for long-term care. I think having a registered nurse on site 24 hours a day, 7 days a week, going forward at all our long-term care facilities across the United States, as well as improved staffing accountability for long-term care is going to be so important, and help initiatives like what Tracy did be more successful, right, for sustainment going forward. So that just came out, and I hope CMS has announced it. I encourage you to go to the CMS website about long-term care and nurse staffing rules, because that I think is very good news. We didn't get everything that we wanted in those rules, but we certainly took a big step forward, I think, this year. So that's all I wanted to say. Thank you.
Thank you for sharing.
Dr. Walgas. She was a huge part in multiple challenges over my project, and she was a great guidance. Thank you.
Yeah, and in the chat also, Tracy, is a comment from a director of nursing locally here, Dawn Anderson, saying, thank you for confirmation of the importance of doing huddles. She did note that they struggle with staff wanting to make this change. So I just was a little curious about, even though you didn't gather that quantitative data or qualitative data, did you get any feedback from staff anecdotally about their experiences related to huddles that, because when you went over the information from the lit review, it was very clear that there's, the literature shows a lot of really positive benefits. You spoke about communication and improving teamwork that came through your data collection. But there's many other benefits also. So I'm just curious if the staff acknowledged any of those things as well.
Yes, Janet, thank you. They did, when I first introduced, I was there for quite some time because I was also getting my precepting and my precepting practicum hours. So I was there for a significant time frame working there and just talking to them and telling them about it and just kind to, I guess, move off of any of them. Some of them were familiar with huddles in an acute care setting. Some did not know. So just giving them and constantly having them part of this and letting them know this is not just me, that I want us all to work together, that really helped. And they also, again, kind of gave me that at the end, unofficial of how they felt and how they appreciated it and how they liked doing, the way that they were communicating and knowing and felt more of a team, especially the aides. The aides really appreciated knowing a little bit more about the patient and their well-being, or maybe what's going on with their health in a setting. So I definitely think that they all were appreciative of it and experience. And then even knowing, we think in healthcare, and like I said, when I first did this, I've been doing huddles for years in acute care settings, but we don't realize in the outskirts and the outpatients that they have no idea, and they're lacking that. So sometimes just a simple, bringing that together and keeping it very simple with so much valuable information that is shared in such a short time.
Thank you. To kind of go off that, I think a question I had was just based on kind of what you've learned from this project, but also your background as an acute care nurse and implementing huddles and working in long-term care. What do you think not only healthcare organizations, but more from an individual level can can facilities do to kind of create a more sustainable huddle program?
I think one thing is getting the education involved, having these discussions. And I think, helping them. And then also even getting the staff and just asking them, maybe just doing an anonymous survey or just talking to them one-on-one and getting their overall, and then introducing it and saying, this is what we've seen. Sometimes, like you said, the resistance to change. But I think if you've got that leadership and that promotion and in keeping that consistency, then they realize it and then they appreciate it.
Yeah, very nice. I see a lot of praise in the chat. Ashley Clark said, nice job. Crystal Hockenberry said, wonderful presentation. Diane Barish asked, she said, great job, Tracy. I know you touched a little bit on the interdisciplinary PTOT speech and getting housekeeping involved, but she asked, did they include other non-clinical staff such as activities or dietary?
Did not. And that would again be some of the limitations that we could reach out for. With this project, they wanted to be like obviously several departments, they're all, but they wanted just closely more of the communication for the patient safety and teamwork. But definitely that is another area and a very good point to expand on. And then also including those different departments involved in it.
And she did also kind of add in, do you see the potential for use of technology to help with the sharing of updating of information, such as the use of an app?
That is a very good question. And it is something that I think with as technology continues to move forward, there would be something that they could definitely look into. Just integrating something again, I thought this was very simple, but it was like an eye-opening when we brought up the suggestion of a huddle board to be able to reiterate. So just so that, is having that right there. And in looking forward to, I'm sure with the cost and everything with technology, but I'm not saying that that's not too far out in our future of starting to have use of technologies and apps for that communication.
I think that's a good point, is that like it seems like that Huddle, that board, just a whiteboard even, was a great space. It almost kind of acted as a meeting place for people to
Yeah.
come and ask for support, and kind of know that if they go there, that they can have like additional information or kind of have a conversation, which is nice.
Right.
Kimberly Strife asked, I would think that job satisfaction would increase for the aides who participated. Did you happen to see this?
So unfortunately, because it was a shorter time frame, and that's one of the limitations, I feel that if we would have extended it for a longer study, I definitely think that could be something that we could see. And again, this was in the summer. That would be a part of limitations to doing it not during like the vacation times, and the shorter duration of extending it in a longer time frame, and then not said during the time frame of a summer, maybe of in the fall where less time where people were taking off. And I feel definitely that there would be a positive and a change in turnover and attitudes and perception.
Nice. Ashley Clark, a fellow DNP student, she said, Tracy, my DNP project was overcoming barriers to nurse bedside shift report. So I can really relate to aspects of your topic project and the importance. We have Janet Knott, who said, great initiative and project. Do you foresee this being implemented at other long-term care facilities? And if so, how would this information be communicated?
So a combination is, first of all, with something like the CGNE series, getting the word out. And that's why I was so elated to, get the word out there and say, I also teach clinical in a long-term care facility and have brought this up to them of something to consider. And in addition to even being there to guide or assist as something in addition, like myself as a contractor, to come in and help facilities, almost like getting my little flyers out and handed out. But it is definitely something that just getting the word out and realizing that that's what was brought to my attention, that this is important, not just in the acute care setting, but in long-term care, and that it can be, and I've proven it, that it is possible.
Well, similarly, Marianne Ventura mentions that this was very enlightening and very needed. She's thinking about incorporating these concepts into the professional role development class to inspire students to be more aware so they can implement it in, various settings and help facilitate this. So
awesome.
Yeah.
If she needs help, don't hesitate, Marianne, to reach out to me or email me or reach out to CGNE and they'll provide my information. Sometimes I feel like I always tell everybody my information is out there and I'm not hard to reach or contact at all. And I'd be more than happy to help because this truly is near and dear to my heart, especially when it comes to patients. I always say, even graduating with my doctorate, I love bedside care and taking care of those patients because that's what I've always set out to do, is taking care of the patient and improving healthcare.
Love that.
Thanks.
Beth Ann Reed also says, do you think, she's saying great job, as many people are in the chat. She's asking, do you think the consistency of residents in care communities rather than the turnover of patients in care is a barrier for huddles in the long-term care setting?
Good question. This project, like I said, was implemented in the short-term rehabilitation. So there was, obviously rotation of the patients or the residents. But, the huddle design, again, that would be to adapt to if it's a long-term care or, on the skilled side and where that you could adapt it to fit the needs for that department, because I feel like there's always something to discuss, there is always, maybe even if it was 3 times a week, but you can definitely adapt it to fit the needs. And that might be something that they would need to continue to do. Okay, let's try this, and being consistent with it by adapting.
Yeah, that's great. Marianne Ventura commented that she already emailed you.
I'll get to it after this seminar.
Yeah. We have Martina Rose from Germany. She said, wonderful presentation. Thank you. Marian Adams said, great job. I guess we sometimes get undergraduate students and other students on our seminars here. So I was wondering if you could just speak to kind of the process of how you developed this idea to implement this project in the first place.
So I'll keep the very short version because, like with anything, and I don't want to scare any of our graduate students, but there is a process and you have to be prepared for a lot of challenges, obstacles, riding through the storms. And so my original project did not go as planned. Of course, it was right at the time and continuing with COVID. And so this was brought to light to me as it just kind of like fell into my lap through clinical. And then I happened to be on a meeting and they were discussing about leadership and change. And something was brought up about huddles and long-term care. And that kind of like threw a little light bulb on me. And I started doing some further investigation and thought, well, and again, I was kind of taken back because I'm like, doesn't everybody do huddles? And not realizing that that it was not implemented in long-term cares. And then I realized it, like I said, as I teach clinicals in a long-term care facility, that they don't. So that's kind of how, and then it just took off from there.
That's
knowing
it's
and building.
A good, I mean, as a nurse, you already have those skills, but a true testament to resiliency and adaptability and kind of overcoming kind of obstacles, which is I'm sure it's helpful for the staff even you're working with to see that even in your process you're kind of modifying and adapting and working through those things. So that's great. We probably have time for about one more question. We'll see. I don't see anything coming in. I guess one question I had, that the sheet that you had pulled up, it was the safety huddle agenda. Did you develop that yourself? Or was that a part of team steps? Is that part of like the system, or did you implement that yourself?
So that was a combination with myself for them to guide them and to be able to. There's several examples, and Team Steps did, suggest with the huddles of a guidance of it, but they didn't really give examples. So with myself and the team of the RN, the LPNs, and even, the staff, we comprised, and I actually made 3 adjustments on it because the first one, we kind of put it in there and then we made some adjustments and kind of the layout and what was the importance of needing to be discussed. And again, that's something that, with feedback of staff and to give, to see what their input. And I think that really helped too, that it wasn't just the RN or administration. We wanted information from the LPNs, from the aides, and what needed to be discussed or the importance.
Nice. Great. Well, we'll wrap up here. Want to say thank you again so much, Tracy, for the wonderful presentation, and congratulations on the completion of your doctorate of nursing practice. And thank you to our audience for joining us today. Just a reminder to please keep an eye on your email inbox later this summer, as we'll be sending out the announcements for our fall seminar series. As a reminder, when we when we close this session, the post-event evaluation will pop up in your browser, but you will also receive the link to the evaluation in an email tomorrow within 24 hours. And then if you're looking for RN contact hours, it just needs to be completed within a week. Thank you all for joining us today, and have a great rest of your day.